So during this session, we're going to talk about why immunotherapy, which has led to such remarkable progress in certain indications like cutaneous melanoma, non-small cell lung cancer, and others, but the outcomes for patients with liver tumors have been nothing short of unimpressive. And we think there are two critical barriers that are limiting the ability of immunotherapy to work more reliably, to induce those deep, durable responses that we see with immunotherapy in liver cancer patients, both primary and metastatic. And that's what we're going to cover during this session. So I'll briefly introduce the three speakers and panelists. We have Alex Kim, the medical director at National Vascular Physicians. Myself, Stephen Katz, I'm the chief medical officer at TriSalus, and I'm not an interventional radiologist. I apologize for that. I'm a surgical oncologist and I practice at Brown. And we have Rahul Sheth, associate professor of interventional radiology at MD Anderson. So we'll begin with Dr. Kim to talk about one of the two critical barriers that we think is limiting immunotherapy success for patients with liver tumors. Dr. Kim.
All right, thank you. So I'm going to talk about the concept of intratumoral pressures, which I think is a very critical concept for interventional radiologists to understand, but it's something that we don't often think about when we give our local therapies. So if I were to take a random survey in the room and ask people if they're giving small particles, 100 micron particles versus large particles for chemoembolization or radioembolization, whatever embolotherapy you're doing for liver-directed therapy, I would guess that the majority of people would favor the smaller particles. But the concept that the particles will provide deeper penetration, maybe get a better embolic effect, deliver your chemotherapy or radiation more effectively. And I think that's a very appealing concept, but one thing that we don't think about is how the intratumoral pressure actually affects our delivery of our particles into tumor. So intratumoral pressure, there are two major components of this increased tumoral pressure. One is the increased interstitial fluid pressure, and the other is solid stress. So interstitial fluid pressure develops basically because of neoangiogenesis. Your tumor grows, your vessels grows to try to provide blood flow to the tumor, but these vessels develop abnormally. So your arterioles have incomplete smooth muscle layers, your capillaries are leaky, your lymphatics don't develop completely or don't develop at all. So you have fluid extrusion into the tumor. And on top of that, you have solid stress, not only from the tumor that's developing, but from the fibroblasts and other interstitial cells that grow that actually compress your vessel. And we believe, we actually know that this kind of limits the way that we deliver our particles. So if you're depending purely on cardiac output to deliver your particles, you're really only getting to the periphery of the tumor, even if you're using small particles. And how do we know this? Well, we have pathologic data that shows this. So this is a pathologic study that was done on Y90 patients, 2 resin, 2 glass, 2 HCC, 2 colorectal patients. And what they found was that in the path specimen, the majority of particles were embedding in the periphery of the tumor. We also have evidence in chemoembolization. So during drug-eluting bead TACE, we also know that the majority of the particles embed in the periphery of the tumor. So in this study of 9 explant patients, the majority of the particles were actually outside of the tumor. And you could see that even the particles that penetrate into the tumor are within a couple of millimeters of the tumor. And why is this important? Because we know that necrotic tissue is actually associated with deeper penetration. Your chemo delivery depends on tumor penetration. So if you want better necrotic results, you need to have that tumor penetration. So how do we do this? How do we improve this? So one of the answers we believe is through pressure-enabled delivery. So when these types of catheters were first developed, they were developed as an anti-reflux tool. And this is a great study because that's what they were trying to look at in this animal model. So this was a pig study of 3 pigs, 1 kidney embolized with a standard microcatheter or an endo catheter, the other kidney treated with a pressure-enabled device. And as you can see in the pressure-enabled device, there was very little reflux into the upper pole of the kidney, as opposed to the endo catheter. So they proved their point, right? But if you could look at, I'm not sure how well this projects, but if you look at the very periphery of the kidneys, you could see the difference in penetration of the particles to the capsule. So in the pressure-enabled catheter delivery, you're seeing particles go all the way to the capsule. As opposed to the endo catheter, you have a 0.5 centimeter, a centimeter margin between the capsule and the end of where the beads are. So with a standard endo catheter, you're not able to deliver with enough pressures to overcome that pressure barrier that you're seeing at the end of the kidney. And we also have clinical evidence that demonstrates that this type of delivery actually works in the manner to overcome intratumoral pressures. This was a retrospective study comparing patients who underwent TACE using an endo catheter versus pressure-enabled delivery. And you could see the clinical responses, the objective response and pathologic response were clearly higher in the pressure-enabled group. What's really fascinating is when you look at the ratio of the particles that went into the tumor versus background liver, there was a clear benefit of tumor delivery, particle delivery into the tumor. So we're shifting that T to N ratio, delivering more particles into tumor, less so in the background liver. It's kind of what we're trying to do using arterial versus venous differentiation in liver cancer, but we're able to augment that using pressure-enabled devices. Furthermore, this was another study that kind of demonstrated that in patients who underwent mapping angiogram. So this was a very clever study done in the University of Tennessee a few years back, where they performed 2 mapping angiograms on the same patient on the same day. So first mapping angiogram with a low dose MAA, second mapping angiogram 6 hours later with a higher dose MAA, and they randomized what catheter that they were going to use first, the standard microcatheter versus pressure-enabled device. And what they found was that there was an increase of about 70% of MAA deposition into tumor and a decrease of 58% in the background liver. So same thing that we saw on the prior study, but now in the potential Y90 population using MAA. And more recently, a European group actually looked at the deposition of the dose that was delivered into the tumor. And when you're using the pressure-enabled device, you are able to deliver a higher amount of actual radiation, Y90 radiation to the tumor, as opposed to patients who were treated with a standard microcatheter. So when I talk to other physicians, other IRs about pressure-enabled delivery, one of the questions I always get is, well, where's the evidence? Where's the clinical evidence that shows this? We don't have a phase 3 randomized controlled trial. That's not really going to happen. But it's clear that in every study that's been done, whether or not it's in chemoembolization, radioembolization, mapping angiogram, preclinical animal studies, CAR T-cell treatment, the results are always the same: more delivery into the tumor versus background liver. So that's all for my part, and I'll hand it back to Dr. Katz.
Thanks, Alex. So as I mentioned when I began, we've seen such incredible things with immunotherapy, checkpoint inhibitors, cell therapy, autologous CAR T cells, allogeneic NK cells, cutaneous melanoma, lung cancer, lymphoma. But the results for patients with liver tumors and pancreas tumors have been very disappointing. Even in HCC, where you have checkpoint approvals, the response rates are still only in the low 30s, which simply isn't good enough. Far fewer than half of the patients are actually benefiting from these drugs. And we think delivery is actually an incredibly important reason why that is. So traditionally, medical oncologists and surgical oncologists have really been the ones driving immunotherapy development and discovery. And I would argue to those of you in this room that interventional radiologists should be playing and will be playing a very prominent role as immunotherapeutic approaches, novel approaches are developed for patients with primary and metastatic liver tumors. And I'm going to go through some data and thinking behind why we feel that is in fact the case. So we think of interventional immunotherapy, getting interventional radiologists to really play a central role in developing novel immunotherapeutic approaches and platforms for these patients. And here's the mission statement: to enable solid tumor immunotherapy with regional delivery approaches to treat tumor microenvironment immune dysfunction and optimize therapeutic index. For example, if you think about cell therapy, when we give patients CAR T cells into a vein or a port, we know from preclinical studies and from human experience that less than 10% of the dose is even going to make it to the liver. And then when you factor in the problem of intratumoral pressure, far fewer cells are actually going to make it into these tumors. And so when we think about how can interventional radiologists play a role in immunotherapy development, it's really leveraging these regional delivery approaches and taking advantage of innovative delivery technologies. So here are the key challenges in treating solid tumor patients and liver tumor patients in particular with immunotherapy. So why are patients with primary or metastatic liver tumors resistant to immunotherapy? It's not just that we're not delivering it effectively when we give it systemically. There are specific immunologic barriers, which I'll cover in a moment. Can we reprogram intrahepatic immune cells, which are suppressed at baseline, to enable checkpoint inhibitors or cell therapy? And we think we can. And can interventional immunotherapy approaches optimize the therapeutic index? Meaning, can we get more cells and more checkpoint inhibitor into the liver versus systemic off-target sites, which leads to immune-related adverse events? And the programs that we're leading, which we call PERIO, for pressure-enabled regional immuno-oncology, are really just focused on two organs, the liver and the pancreas, and we're talking about the liver today. The two problems that I've mentioned, intratumoral pressure and immunosuppression, which is very specific, unique, and distinct within the liver. And we think these problems are common denominators across multiple indications. So whether you're talking about HCC or intrahepatic cholangiocarcinoma or metastatic colorectal and so on, we think these problems affect immunotherapy performance across indications because these problems are specific to the organ. And we'll talk about two solutions. Alex told you about pressure-enabled drug delivery, and I'm going to talk about a drug, a toll-like receptor 9 agonist that we're currently studying across several indications in phase 1 trials, SD101, which we think can reprogram this dysfunctional immunologic milieu within the liver. And so this is what got me interested in pressure-enabled drug delivery. Again, I'm a surgical oncologist, not an interventional radiologist, so I don't play with catheters too often. But I was doing a phase 1 study where we were delivering CAR T cells targeting CEA intra-arterially for patients with metastatic CEA-positive adenocarcinoma. So these were mainly stage 4 pancreatic cancer patients. And when we looked at pre and post biopsies, compared them and looked for the CAR T cells by PCR, we were seeing virtually no product, no CAR T cells in the tumors, despite the fact that we were giving them intra-arterially directly into tumor feeding vessels. And I learned about the problem of intratumoral pressure. And what we found was when we did a subsequent study using the pressure-enabled delivery device, we increased CAR T cell presence in these high-pressure liver tumors 5-fold or 500%. So that's comparing the orange to the dark purple bars. So just by changing the catheter system, we were getting much deeper penetration and more reliable delivery of the CAR T cells. And one of these patients in that study with stage 4 metastatic pancreatic adenocarcinoma had a complete response on PET scan. It was a PR on an MRI, but this was durable for 2 years. And you're looking at the tumor markers decrease. This patient was resistant to FOLFIRINOX, and the biopsy showed near complete fibrosis. And so we believe that the improved delivery of the cell therapy product changed the game for that patient. And one of the things that I've studied for many years is how the unique biology of liver immune cells plays into all of this. The liver is a very tolerogenic organ. Everything we eat passes through the liver, so immune cells need to be suppressed. Unfortunately, cancer cells hijack this and turn the immune system off even further, so the patients don't respond to immunotherapy. And there are multiple cell types that play a role in this, like myeloid suppressor cells and regulatory T cells. There it is. And we have to find ways to turn these cells off and get CD8 T cells and CD4 T cells, the ones that are actually going to destroy the tumor cells, to work more reliably for immunotherapy to perform in these patients. And that's what we're trying to do by combining a toll-like receptor 9 agonist with the pressure-enabled delivery system. And so does this matter clinically? And so this is a paper that was published in Nature Medicine, not from our group, where the investigators showed that in patients with melanoma, lung cancer, and renal cell, when they were treated with checkpoint inhibitors, the presence or absence of liver metastases was one of the strongest predictors of response to the checkpoint inhibitors. So just the mere presence of metastatic disease in the liver was preventing these patients from responding to checkpoint inhibitors. And we think we know part of the reason why, and the authors spoke to this. The presence of liver metastases was associated with an expansion of these suppressive cells, these myeloid suppressor cells, which they found at higher levels circulating in these patients. So we think we really need to address the immunosuppressive problem within the liver to enable these patients to respond to checkpoint inhibitors and cell therapy more reliably. So the drug that we're studying, as I mentioned, is SD101. It's a toll-like receptor 9 agonist. Many of you may be familiar with TLR agonists. There have been many studies using direct needle injection approaches. A company called Dynavax studied this drug for cutaneous melanoma in combination with pembrolizumab. And what I'm showing you here is that in that setting where delivery is not an issue for superficial lesions, easily accessed with a needle, the response rate was increased from a historical rate of 32% up to 79%. And this comes from reprogramming the tumor microenvironment. So we know this drug can do that if delivered effectively. And the other thing that is very interesting about this drug, it's a class C TLR9 agonist, which among other things means that it's more effective at eliminating or depleting these myeloid suppressor cells. And so this is among the reasons why we're so interested in using this for intrahepatic indications, both primary and metastatic. And we've shown in a murine model, which is what I'm showing you here, and we model the pressure-enabled approach. We give the drug regionally to the mice with liver mets directly into the portal vein under pressure. And when we compared that to systemic delivery, we saw a significantly increased depletion of myeloid suppressor cells and also immunosuppressive M2 macrophages. So the delivery approach mattered significantly in terms of the performance of this TLR9 agonist. So this is exactly what we're doing in phase 1 now for uveal melanoma liver metastases and HCC and cholangiocarcinoma. We're testing whether giving this drug regionally under pressure into the liver can enable this reprogramming of the suppressive immune environment intrahepatically to boost checkpoint response rates. And here's the tumor control data from that same murine study. The black line is showing you the combination of the regional TLR9 plus checkpoint, and the red and purple lines are the single agent groups, just checkpoint or just the regional TLR9. So by combining both, we're getting significantly better tumor control, which is what Dynavax saw in their cutaneous melanoma study, and what we're hoping to see in the studies I mentioned a moment ago. And so when we think about how we're combining SD101, the TLR9 agonist, with pressure-enabled drug delivery, we think of it as a therapeutic platform, because again, these problems are common denominators across, we think, all intrahepatic indications, both primary and metastatic. We think the drug can reprogram the immune microenvironment successfully, and the delivery system can enable the drug to perform well. And so here are the studies that are ongoing or soon to be coming online. So the uveal melanoma liver met study is open, and Dr. Sheth's going to be talking about that in a moment. We just opened the second study for HCC and intrahepatic cholangio. And later in the year, we'll be moving into PDAC liver mets, and the following year, likely colorectal liver mets. And we have a separate program with a separate delivery technology with the same principles for locally advanced pancreatic adenocarcinoma. So again, we view this as a platform because we think the immune dysfunction problems are very similar across these indications, being based more on the organ biology than the tumor histology itself, and the delivery technology we think will enable a TLR9 agonist to work well. And so we've actually treated 7 patients so far, and Rahul will talk about that a little bit. The safety data, I'll just mention quickly, looks great. We haven't had any immune-related or serious adverse events related to the drug. And we're seeing some very exciting TME reprogramming, these effects that we were hoping to see with myeloid suppressor cells. We're actually seeing that happen in the liver tumors. And that was just single agent. And soon we're going to be moving into the combination cohort with checkpoint, hoping to see the boost in response rate. So just to summarize quickly, our goal as a company is to drive a deeper understanding of how immunosuppression in the liver drives immunotherapy failure, to develop approaches based on this platform to boost checkpoint response rates in these patients and ultimately cell therapy as well. And we really want to enable the ability of interventional radiologists to play an increasingly important and prominent role in the development of novel immunotherapy approaches for these patients, because we think this type of delivery approach really can yield significant advances over systemic. So with that, I'll hand it over to Dr. Sheth. Thank you for your attention.
Hi, good afternoon, everyone. I'm Rahul Sheth. I'm at MD Anderson, and it's my pleasure to talk to you guys about our experience with the PERIO 1 trial. The idea with this trial, as was mentioned, is we're combining the PEDD device that Alex talked about to overcome the barriers to delivery with the immunotherapy that Stephen talked about to try to get local and ideally remote immune activation. These are my disclosures. We'll first talk about the rationale. I know the previous speakers discussed that, but I'll sort of give you my perspective on that. We'll talk about PEDD in the real world, basically what we've learned from the experience with the catheter, and then what we've seen in the trial with the PERIO 1 study. So just to sort of take a step back, the idea here is kind of illustrated in this cartoon. When patients who have a dormant immune response to their tumor receive checkpoint inhibitors, as in figure A, they usually have a durable response. But unfortunately, most patients are like the tumor in figure B, where they have really an immune desert or an immune excluded phenotype. And we have to do something to that tumor to drive in immune cells so that when they receive checkpoints, they have a durable response. The pharma industry has been working furiously to develop therapies that can be delivered locally into the tumor that can turn these cold tumors into hot tumors. And so the concept here is you deliver that therapy into one site, you create immune education locally, which causes not just local tumor eradication, but ideally sort of systemic surveillance and tumor eradication. So this is the concept. The idea of turning cold tumors hot is certainly not something new. It's not unique to us or to this trial. But I just want everyone here to kind of take a step back and think about the implications of these types of therapies. So if we're able in our specialty to demonstrate that these approaches work, I think that really has the opportunity to revolutionize IR. We can prove ourselves as the FedEx or the UPS for immunotherapy. We can kick down the doors for all the other malignancies for which immunotherapy is used, which is the majority of cancers. So it gives us the opportunity to really be involved in the care of patients across the entire spectrum of cancer, which is why I'm very excited about it, and which is why I think you all should be very excited about it. So let me just kind of show you what we're talking about. This is a trial where we directly delivered a TLR agonist similar to SD101 into a site of disease. This is a patient with metastatic melanoma. As you can see in the bottom left image, he had tumor everywhere. We injected this one little axillary nodule in the middle picture. We put him back on checkpoints, which he had previously progressed on, and 5 years later, he's cancer-free. This drug went through phase 1 and phase 2 trials with fantastic results, but it failed in phase 3. And if you speak to the PI of this study, the issue was delivery. The drug, once it got out of our institution and in this global phase 3 trial, couldn't be reliably delivered where it needs to be delivered. And so even though these drugs might be fantastic, you still have to get them where they need to be. And what we've learned from a variety of the trials that we're conducting is that it turns out that's a harder problem to solve than you might think. So certainly we can stick needles in anywhere. We can stick a needle into the tumor and be sure it's in the right place. But when you deliver the drug, who knows where it's going to end up? And so this is a patient with a liver metastasis. The blue dotted line circumscribes the tumor. The green highlighted area shows you where the drug went. And then the red shows you where it went outside of the tumor. So you can see that most of the drug actually spilled out. So observations like this really convinced us that we need to think about ways to deliver therapies that are much better than our conventional approaches. We've also been measuring the intratumoral pressure, like Alex mentioned, in our lesions when we do these injections. So if you look at that chart, the red lines are for liver lesions. Liver lesions tend to have the highest intratumoral pressure at baseline. When you inject, again, percutaneously in this case, the pressures get astronomically high, and then they come back to baseline afterwards. So when we're thinking about delivering drugs into tumor, of course, the baseline elevated pressure makes it challenging. Increasing that pressure with delivery is actually not the hard part. We can deliver drug at extremely high pressure. The challenge is making sure it goes where it's supposed to go and not leak out of the tumor, which is what happens when you do this percutaneously. So if you switch approaches and go to transarterial, that's one advantage because now you can kind of cover a larger area. But you still need a way to prevent the backflow because just like with any other therapy, if you generate too much pressure, it's going to find the path of least resistance, which could be into a collateral or backwards down to the main branch. So that's where the PEDD catheter comes in. So I just want to show you some cases. Before we started the PERIO trial, I wanted to get better experience with the catheter and understand what its capabilities were, what its limitations were, so that we were well situated when we started the trial. So these are a few cases, both in liver and elsewhere. They're all bland embolizations, so any of the therapeutic effect really has to do with the degree of embolization using bland microspheres and not any additional chemo or radiotherapy. So this was one of the first patients I used the catheter on. This is a patient with metastatic adrenal cortical carcinoma, so not a terribly common cancer, but he had large liver metastases. And I had previously ablated, this, that, and the other, but these lesions were too large for me to ablate. So I said, well, let's try this catheter, let's try this embolization. So, we got selective into segment 4 and segment 2 branches, embolized, and we'll talk about what stasis means with this catheter, but, embolized it thoroughly, and he had a, nice metabolic response on the follow-up. So this was very encouraging, but you could easily argue, well, it's a hypervascular tumor, who cares? I can embolize hypervascular tumors all day long and have great responses. So let's, up the stakes a little bit. So this was a patient with a metastatic sarcoma. So you see a large left hepatic lobe lesion. In the bottom left, you'll see the angio. This was not hypervascular by any stretch on his angiogram. But when we did the embolization, you could see really nice staining on the immediate CT. And then 6 weeks later, and now 6 months later, you can see that he's had a really nice durable response to that. So cases like this really showed me that when you do the pressure-enabled delivery with just bland embolics, you can really drive in the therapy deeply into the tumor, and that has potential therapeutic benefits. This was a kind of unusual case, which I'm still trying to wrap my head around, but this is a patient with metastatic renal cell carcinoma. So you would imagine it's going to be hypervascular. In her case, it was not. So top left image is her diagnostic scan. Top right was with a conventional microcatheter doing an procedural arterial CT. So you can barely see any of the tumor. When we did the same run with the same settings with the TriNav, you saw much better perfusion to the tumor. And so we used that to embolize the tumor, and she had a great response. So, seeing like this makes me sort of encouraged that even hypovascular tumors can be treated. And this was another sort of cancer, or another lesion kind of along that paradigm. This was a metastatic sarcomatoid prostate cancer to the right hip. We embolized this, and he had a really great response afterwards. So kind of my take-home points from my experience with this catheter is the conventional endpoints that we think about, with standard microcatheters, I think are irrelevant because you can essentially just keep pushing your embolic. I think we need to think about a new way to standardize endpoints if we're going to use these microcatheters. And it's not to say that you can't reflux with it. It's just that when you do reflux, it usually means you've reached extremely high delivery pressure, and that's probably a good time to stop. Okay, so let's talk about the study. So as was mentioned, the idea with this trial is to combine the pressure-enabled drug delivery with the TLR agonist SD101. We're delivering it actually to the whole liver, because as Stephen talked about, these MDSCs are not just confined to the tumor itself, they're across the whole liver. And so there's sort of an immunosuppressive landscape that we have to reprogram. It's a treatment intensive trial. So they get a total of 6 treatments, all angiographic delivery. They have biopsies pre, on treatment, and post. So before we started the trial, of course, this is the first time anyone had done this. Is it safe to do 6 groin punctures Q weekly? So it's 3 treatments, break, 3 treatments again. So is that okay? We're putting the microcatheter in the same artery over and over and over again. Is there any issue with spasm, dissection? Does the drug itself cause some issue with the endothelium that will affect the deliverability in subsequent treatments? Can our catheter get there? Not everyone who's going to be doing this has done 1 million, angiograms. So with a spectrum of experience, is this capable for everybody to use? And then are the patients going to be okay with this? I mean, this is obviously quite a bit to sign up, and are they going to sort of tolerate the treatment regimen? And the way it's delivered is we hook the drug up onto an infusion pump and then hook that pump up into the microcatheter. So just from a sort of logistical standpoint, can you get a big department with lots of people to understand how to use these devices? So, we've treated 5 patients at our institution. We've seen every variety of hepatic arterial anatomy with curly Q, common hepatics, replace left, replace rights. We've had 0 issues with getting the catheter where it needs to go, regardless of operator experience. We've had 0 issues with groin puncture complications. And as Stephen mentioned, we've had 0 issues with toxicity from the drug itself. So, in terms of our experience, we've sort of been very pleased with all of these initial, questions, concerns that had existed before, and have really been able to kind of streamline the process so the patients are able to tolerate these repeat therapies. So, as Stephen mentioned, some of the prelim data in terms of the biomarkers is very encouraging. Very much looking forward to sharing that, down the road once we get more data. But that is our experience with this trial. So in summary, what we're seeing is real, this abscopal effect. We're seeing it much more commonly than just sort of these intermittent random case reports that might pop up here and there when we use these intratumoral immunotherapy agents. We as IRs really need to think about our technique when we deliver these drugs, and that's really the value that we bring to the table. And that's what gives us a seat at the table with all these pharma companies and the immunologists. I think PEDD is a major step forward towards addressing these needs. Thanks a lot.
Thanks, Dr. Sheth. Are there any questions in the audience? Yes.
So over the years, that number of different approaches during MDSC and T-reg depletion. Obviously, this cyclic phospholipid, a bunch of other ones. Why would you necessarily need to turn the direct agent without the long safety profile to carry out that effect? Just to say, why not just combine one of these other approaches with, arterial therapies? Why was that chosen as the go-to?
Thanks. That's a great question. So for those of you that didn't hear the question, it was, why did we choose intraarterial SD101? There are many other strategies available to deplete MDSC or Treg. Why did we choose this specific one? A couple of different reasons. One, as I alluded to very briefly, the biology of MDSC in the liver is very unique. So when you look at MDSC in the liver and you compare it to MDSC in the lungs, for example, or the spleen or lymph nodes, they're actually quite different in terms of how they're programmed, what drives their expansion, what mechanisms they use to suppress T cells, what subsets predominate, within the liver are very different. So you do need a drug that's going to work preferentially on liver MDSC. And for reasons that I won't get into too deeply here, class C TLR9 agonists are ideally suited for that. The other reason we chose TLR9 is that immunosuppression in the liver is an incredibly complicated problem. And so the simplistic view I'll put forth is if you target just one pathway like IDO1 or arginase that MDSC leveraged to suppress T cells, you're missing scores of others. And so the nice thing about a TLR9 agonist, particularly class C, is that they do specifically deplete liver MDSC through apoptosis, also reprograms them into M1 macrophages, but at the same time, the drug is broadly reprogramming the tumor microenvironment by stimulating dendritic cells and B cells and NK cells. So we think that specific plus broad effect is what you need to tackle this very complicated immunologic problem. And then the delivery issue, I think, is part of it as well, because when you don't get high enough concentrations of the drug in the liver and you get most of your effect extrahepatically, you end up with a lot of immune-related adverse events and not a lot of clinical benefit. So that was the thinking behind it. Mm-hmm. So that's a great question. Why did we choose weekly dosing? The answer is the drug's been very well studied. So Dynavax studied SD101 in over 300 patients, mostly in combination with checkpoint. And what they learned when they looked at the pharmacokinetics and the pharmacodynamics, pharmacokinetically, the drug actually goes away very quickly, but the immunologic effects, the PD, actually persist for a week. So if you look at T cell changes and cytokine changes in the periphery after a single injection, you see them last about 7 days. And so that's why we chose the weekly intervals for the dosing. Yes.
Yeah, great question. Just to reiterate, I had mentioned we need to change our embolization endpoints, and so Dr. Suwan saying, well, what are your embolization endpoints? So I'll tell you, I'll give you two answers. One of them is sort of facetious, but honest, and the other is I think the more formal answer. So the honest facetious answer is I go until I chicken out, because you really could deliver beads for the most part until you ran out of beads, I feel like sometimes. But I think realistically, when I start to see reflux from the catheter, that tells me that I've saturated that vasculature, and that's sort of my default endpoint at this point. If I haven't seen that after, a vial or two in a selective artery, then I chicken out.
Yes. Here again.
Size of particle volumes to, for example, a putative dose distribution of your vascular downstream vascular. One thing that we found in our vat studies, different log sizes, things like that, the types of logs, you can find some of them that are preferentially extravascular and localization prevention. And some of them end up staying with the interstitial portion of the part, whether in the vasculature or whether in those virus panels. So now you're adding caveat, shoving it up these things with such force, such place the tumor. Like you said, the body full of particles or something. So is there some standardization there where you can say, okay, well, I have a given distribution, the volume that I expect, and for a particle this size, I expect embolized to this, getting at a more scientific way. So you said you have a pump, which we do with how is that
Yeah, sure. So I'll just paraphrase the question again. So how do you know is there a relationship between the particle size and the distribution, and how is that different with PEDD, and does the addition of the pump help normalize some of that? Is that fair enough? So it's a great question. In terms of like the first part, which is the dose distribution as a function of particle size, I think an animal study is the way to do it. I don't think that data exists, but I think it's important. I bet there's a lot of extravascular deposition with PEDD, probably a whole lot more than with conventional embolization. And I think that probably helps drive some of the therapeutic responses that we're seeing for these hypovascular tumors. For the pump, so just to kind of clarify, the pump is for PERIO 1 when we do the delivery. That's at a fixed rate, but there's no embolic with PERIO 1. So PERIO 1 is just the drug delivered through the PED catheter. So there's no stasis, there's no occlusion of vessels, and that's just delivered at a constant rate. There's some manipulation during the delivery to kind of pressurize, at a single time the drug into the tumor, but for the most part, it's just a constant rate.
And one of the interesting things about using a drug like ST101 in this way is you also have to think about the biology of the molecule and how it's taken up. One of the questions that we would get when people were first looking at the study is, why would the drug stay in the liver? Why wouldn't it just pass through into the hepatic venous circulation and then go systemic? And what appears to be happening is that the liver has such a high number of TLR9 positive cells, probably more than anywhere in the body. The liver sinusoidal endothelial cells, which are the most abundant non-hepatocyte cell type in the liver, express TLR9, and you have a huge repertoire of immune cells that express TLR9. So it appears that as long as you don't exceed that maximum concentration level, you get a lot of binding and the drug doesn't recirculate. And when we looked for the drug in the blood, when we infuse these patients, you can only detect it for 2 hours at extremely low levels. And in the tissue, the concentration is quite high. So, and with CAR T, it's a bit of a similar story, driven more by integrin and selectin expression on those endothelial cells. So, when you're doing immunotherapy via these delivery routes, you have to also think about the biology of the product and how it interacts with the liver immune cells.
I think also, like, slide come from, we looked at temporal venous, microphone, you mentioned your brain is gut, you bring restaurant, you bring conversation, explain it with the gut, right? That's your immune cell population. The restaurant has to be conversation. Then you head into the liver, that's going to be very different to microphone. You come from the arterial side, which is for the most part, differentiate FBSC one-side populations, right? So you can imagine that different effect if you deliver bolus into the venous side. You may have a higher resonance from that side of the arterial side. So maybe it's not I think that's like done.
I mean, the closest thing that we've done is the mirroring studies that I mentioned were done from the portal venous side, because the artery in the mouse is too small, obviously, to inject. And so we see similar results in the mouse from the portal venous side. Whether that equates to what happens in people, don't know for sure, but it does look similar when we're seeing what happens in our trial on the biopsy specimens compared to the mirroring model. Yes. That's a great question. So it's a fixed dose per patient. The dose comes in a volume of 50 mLs. And as Rahul mentioned, we treat the whole liver, but we give higher volume to segments or sectors with measurable disease. And so volumetrics are done for tumor and normal liver parenchyma, and then that volume is allocated appropriately based on those relative volumes. Any other questions? Yeah.
Just for a little technically, they TriSalus, you operate the standard commercial catheter, so weight vessel size is operated too big or too small. It doesn't function. So given how you're is that an issue at all? Especially people who have
Right, sure. So the question is, there's a range of vessel size for which the catheter can be used. So have you ever run into the issue of the artery being too big or too small in terms of delivery? So basically the way the trial is designed is we, as Dr. Katz mentioned, we map out the territories that the different, segmental arteries are perfusing. And then when we do our angiograms, we measure the arteries themselves. So if we can get into the right posterior based on the size, then we'll treat from there. If it has to be from the right main only because of size, then we treat from there, and we just add up the segments that we're perfusing in terms of how much volume of drug we're going to deliver. And base the treatment just on the measurements on the procedure day.
Okay, well, if there are no further questions, I want to thank you for your attention and thank the speakers.